Sepsis is a really scary word if you've got somebody complicated in the family.
I think there's many a junior doctor who puts on a front of thinking they understand about disability, but actually they're really scared of disabled children and young people because they don't know where to begin.
Only parents can really know when their children are sick.
You put music on, particularly her very favourite songs, and she didn't smile, then there was something really, really, really wrong.
Even for children with the most complex of healthcare conditions, 99.9% of the time, they should be afforded the same high-quality healthcare as any other child in any other situation.
There's a real intimacy about being sat next to a hospital bed with a sick child, especially a complex sick child.
Hello and welcome to our Paediatric Sepsis podcast series, brought to you by the Royal College of Paediatrics and Child Health and the team from the Great North Children's Hospital, with guest speakers from all over the country. My name is Emma Lim and I'm a general paediatric consultant. And hello from Monica and Johnny at the mixed desk today. So today I've got two special guests in my studio and I'm really excited to see you both. Caroline Docking is a mum, most importantly, mother of Eleanor, who's her eldest daughter, and who I met 3 years ago now. She also has, she's a working mother, and she's head of communications at the Newcastle upon Tyne Foundation Trust Hospital. And it is so clear to me that I need everybody to listen to what you say, because as a mother and as somebody who works in the NHS, I think you bring this really important perspective.
That's very kind of you to say, and I'll try and live up to that introduction today.
Thank you. And I also have Karen Horridge here, who's previous chair of the British Academy of Childhood Disability and also works the Royal College of Paediatrics. And I have a secret confession. I always meet you, Karen, and you always have much more edgy, hip, cool shoes than I do. And I always think, why didn't I wear those shoes? Because A, they look better, and B, you could walk better than me. So I think they are orange Doc Martens, orange camo Doc Martens today. So hello and welcome, Karen.
Thank you.
Karen, what does sepsis mean to you when you think about all those children that you look after for the whole of their lives with such complex health conditions?
So sepsis is infection that's really taken a hold somewhere. But the thing about sepsis is it isn't easy to spot, and it can sometimes be really, really difficult because it goes and hides away in some body part that you've not thought that it would be in. And it can masquerade as all sorts of different things and be really quite challenging. But on the other hand, it's really important to identify early because most of the time it's treatable. But it needs a team approach. You need to be talking to the microbiologists, you need to be talking to the lab people, you need to be talking to other experts to work out what's going on and what the right plan is.
Anybody would think you'd already listened to all the other podcasts. And Caroline, what does sepsis mean to you, and what did it mean to Eleanor?
Sepsis is a really scary word if you've got somebody complicated in the family. It's scary because you know it's more likely to happen to that person in your family. It's scary because it's more difficult to spot in that member of your family. And I think we're all conscious of those people where it's ended badly. You know, we're all conscious through the internet, through social media, of tragedies and young people who have had overwhelming infections and their families were saying there's something not right and they haven't been listened to, and that young person hasn't been treated, and that young person has died and their life has been taken away. And the anger and the distress and the pain that those families have is something that is really scary. And I was always quite worried about Eleanor dying badly in a place where I didn't feel that I was being listened to, and where there was chaos or violence or inappropriate activity, or just for it not to be for it not to be a good experience, and for us to have to live with that forever. And so for me, sepsis is a really scary word. But actually our experience of sepsis when Eleanor did have it after surgery was really positive, because people did listen and people did get to the bottom of it, and people did treat her with dignity and respect and with the appropriate clinical services that she needed. And the team that was around her really responded very well.
I guess one of the reasons that we want to talk today is because children with complex health conditions who are unwell are so hard to spot. It's scary for junior doctors. And I think that to start with, maybe if you just tell us about what happened with you and Eleanor and your experiences of our healthcare system, that might help people to feel what it's like to be in that situation.
Sure, I'm happy to. And so Eleanor is my eldest daughter, and it's really important to say that we've had a very positive experience of care throughout her life. It's really also important to say that very sadly she passed away last year. So, and she passed away in very good circumstances, if we can describe it as that. She was poorly, she was well looked after, it was just her time, and she had what I would describe as a good death, the kind of death that I hoped she would have. Maybe that's a podcast for another day. But I would really like to think back to her 21 years of using services. And Eleanor was probably as complex as it gets. She had really severe physical disabilities from the day that she was born. She also had a very severe learning disability, and that meant that she needed help to do absolutely everything in life. She didn't have very much independent movement. She couldn't speak. She had trouble seeing and heard things in different ways as well. She also had type 1 diabetes, which was an unexpected and additional challenge that she got when she was about 11. She had various orthopedic problems, a little bit of epilepsy, lots and lots of complications. And when you listen to that list, you would expect her quality of life to have been very, very poor, and her life overall to be very, very limited. But it wasn't. Eleanor had a brilliant life. She was happy. She knew what she liked. She knew what she didn't like. She was very good at expressing that to people that knew her. And I'm really confident that her life was fun and lively and valuable, and that she made a contribution to the world, and actually that she continues to make a contribution to the world.
Thank you. We made a film about Eleanor, and I think it was seeing what she did as a teenager and a young woman, some of the things that were so similar to other teenagers.
Eleanor always loved music. That was one of her absolute passions. So she used to really enjoy being outside, going to concerts, going shopping. She used to enjoy the foods that she enjoyed. She had likes and dislikes and preferences. And you kind of ignored that at your peril, because she really would express when she wasn't happy.
Yeah, I think she was such a typical late teenager. She had a phone. She liked going out for coffee.
She did.
She mowed the lawn.
Yeah, she did.
Occasion.
She wasn't that keen on mowing the lawn, but she did get it done. She did lots of the chores around the house, so she would always hang her own washing out and load the washing machine. She went to the hairdressers to get a haircut. She went to the spa. She really did get stuck in.
Great. And I remember, you going back to that thing you were telling me about how she liked music. That was one of the ways that you could tell when she was sick.
Absolutely. So it was very easy to put music on and Eleanor would smile. And you knew that when you put music on, particularly her very favourite songs, and she didn't smile, then there was something really, really, really wrong. And it was also sometimes the way that she smiled, because sometimes she would like a song so much that she would be trying to smile, but she just couldn't quite get there because there was so much else going on in her body. And that wasn't something that most people could see. They would just see the smile or the half smile. They wouldn't see the emotion behind the eyes and the rest of the way she held herself. But that was a really good indication for us about whether she was well or whether she was not well, or whether it was a bit of paracetamol she needed or whether it was something much more serious.
So I think that that's such a great example, because you bring Eleanor to hospital because she isn't smiling when Robbie Williams is on the radio. And of course, the doctor says to you, "What's wrong?" But you can't say that because that doesn't sound right. So you just say, "I know my child's not well." And I think this is something, Karen, that you will have seen time and time again with children with these complex health conditions, that only parents can really know when their children are sick.
Absolutely, absolutely. Parents and familiar carers know their children and young people the best, and we must listen to what they're saying, and we must give them the time and the space to be able to articulate as well as they can, as best they can, what they think is happening. I think there's many a junior doctor who puts on a front of thinking they understand about disability, but actually they're really scared of disabled children and young people because they don't know where to begin. But if they would only begin by listening to the parent carer, to that mother's intuition that all is not well, then they'd be starting in a better place of trust to work out what's actually happening. I think also developing a very structured approach to thinking about the assessment of a disabled child or young person can be really, really helpful, because it gives you an approach to hang things on, and that just has to start with listening.
So what are your top tips when you see these children with complex healthcare needs in the emergency department? What are your top tips for junior doctors?
So the first thing is ask if they've got an emergency healthcare plan, because certainly in our region, many disabled children, those with the most complex conditions, will have an emergency healthcare plan, which has been prepared by the lead clinician in conjunction with the family. And it's basically like a recipe. It tells you what the main health conditions are, signposts you to where the treatment is, and then it tells you if this happens, do that, call that person. It gives you permission to think about how to approach things. Most of all, do listen to the family.
So you both think the first thing is to listen to parents. The second thing is to say, have you got an emergency healthcare plan? Caroline, what did you find most helpful about having an emergency healthcare plan?
I think it's about permission. So when you're a parent and you're taking your very sick child into the emergency department, it's a really, really scary place to be. And it's a really uncomfortable place to be. And you feel very powerless in that situation. So if you think about it, you've had a child who you've seen getting more and more sick, and you can actually cope with quite a lot at home. Eleanor was getting ward level care really well at home all the time. So we've come to the end of our coping mechanisms at home. We know we need help. We've come in and our anxiety is raising as we approach, and we've probably had bad experiences at A&E as well that's being remembered as we're on our way there, often in an ambulance, because that's the critical point that we're at. So what an emergency healthcare plan allows me to do is say, this is the plan. It allows me to take a little bit of control for that person that we first see at the door, to say, this is what you need to do. You need to call this doctor, or you need to give us some oxygen, or you need to do this. This is what I'm worried about, and this is what I'm not worried about. So it really does give you that authority to be able to say, you have to listen to me, and you have to listen to me now. And that's something that I've had experience of doing with an emergency healthcare plan and without an emergency healthcare plan. And I can honestly say it really does make a difference to have that piece of paper in your hand.
So I think that really summarises what Karen is saying. Not only does it have important information, but it empowers you as a parent to be part of the team caring for your own child.
I think that's absolutely right, and it's so important.
Karen, what advice have you got for a structured approach towards children who have these complex health conditions?
So, as I've said, first of all, always listen to the parent carers or get hold of them if they're not physically there, because you will learn that background information, which is just so important. And then it's back to what we're all taught at medical school about taking a thorough history and then conducting a really thorough clinical examination, and probably having a lower threshold for investigations than you would in a child without a complex health condition. Because we know from big studies that have been done that disabled children and young people, particularly those with a learning disability, have much worse outcomes, and up to a third of those bad outcomes are potentially avoidable if people had only followed a structured approach. You don't be blinded by seeing a different shaped body in front of you or behaviours that might appear challenging, and just think how frightened that child or young person is thinking and how stressed their parent carer is. And if you're worried and you don't know what's going on, phone a senior colleague, but never fail to listen to the parent carer who's saying, my child is just not right.
I think the three things you've told us are: listen to parents, have a structured approach to your history taking and examination, and ring somebody who knows that child and family well.
I think that point about listening to parents is not just about being polite and engaging. It's life-saving. So the only person in that A&E department who knows that Eleanor never got a temperature was me. So if you were looking for a high temperature to show that she had a fever, it would never ever come, because her body temperature always ran cold. So if she had a normal temperature, that was really alarming to us. And that's the level of detail that is rarely written, but is actually really, really important to know. Equally, because Eleanor had type 1 diabetes, she quite often went into hospital with her blood sugar too high or too low, but that wasn't unusual for her. That wasn't anything to be particularly worried about. It was the other stuff that I was worried about. It was the struggling to breathe, it was the just not being right, it was the failure to make eye contact that was the thing that was really making my heart beat faster. And it always strikes me that as a parent, I have a very weak voice in saying you need to not follow that Pew's chart, you need to look at Eleanor differently from that. And I think what really helps is when a doctor can really actively listen and take that on board and pass that over to other staff, so that we're not just relying on the normal parameters that you would have for a more average child.
So this is a really, really important point. If you're a child who, like Eleanor, is always cold, and then you suddenly get a normal temperature, that doesn't trigger on this chart.
That's right.
And the second problem is that the chart can falsely reassure you. So it can look normal the whole time, and probably the only abnormal thing is the parent is saying to you again and again, my child isn't well.
I think the other group of children and young people with complex health conditions who can be really difficult to assess are those who are probably mobile, who can't communicate verbally, but communicate through behaviours which other people might interpret as challenging. So there might be seen as a challenge to the team in the emergency department because this young person's running amok, but that young person might have appendicitis. And because they are on the autism spectrum and their pain threshold is set at a completely different pitch, they're not exhibiting the usual signs.
These children with complex health conditions, they might present with increased seizures, but actually they have a urine infection. And I'm sure you've got examples where Eleanor's come in with various things and it was something completely different.
I think also quite often you never get to the bottom of what it is that's going on. So I quite often talk about looking after Eleanor when she's not well as needing to be a bit of a detective. So we kind of, you use every source of information that you have because you know there's something wrong and she can't tell you that there's something wrong. So you kind of use what's happened over the last few days. Have any of the other kids got a virus or a sore throat or something else that might give you a clue. How am I feeling? Have I got something brewing that I've not picked up on yet? And that's quite good for sore throats and things. Then you suddenly realise that actually it must be irritating her in the same way. But also, of course, thinking about top to toe, what is she saying to you? Because although Eleanor didn't have a voice, she could say things to you in different ways. Is it about the way she's holding herself? Is it about the way she's making noises or not making noises? Is she jumping when you touch her in a particular place, or reacting differently when you put her in a different place or in a different position? And I think what I ask for when I come to hospital is for the staff there to help me to figure out what I'm missing. So some of the best examples that we've had of care was around when Eleanor was in intensive care, when she actually did have sepsis. And I have this really vivid memory of me and the consultant surgeon, because it was the day after she'd had spinal surgery, and the intensivist all stood at the end of the bed, none of us knowing what was going on, but all of us knowing that something was going on, and having a conversation to work out the bits that I knew were just as important as the bits that each of them knew. And we had to come together as a team to get to the bottom of what this problem was and how we were going to help her. And it is that complex jigsaw puzzle that none of us had the answer. None of us could say individually what was going on, but together we got to the bottom of it and we were able to help. And that was so reassuring to me, because I knew that I was being listened to, and I knew that I was being heard, and I knew that Eleanor was being respected, and that we were taking her from her starting point and not from the starting point of an average child, because she was never going to be an average child.
I think as a junior doctor, it's those calls in the middle of the night where one of the nurses says to you, I've got a patient with complex health conditions and they're already in for another procedure, and their parent says something is not right. Can you come and see them? And it's really hard as a junior doctor to know where to start. And it is scary. And I think that your point about listening to parents, recognising that together as a team, you may need to do a whole load of things, which include investigations and speaking to other people to find out what's wrong.
I think it's about being proportionate as well, because, looking at some of those scary things, it would be very easy to put Eleanor through a battery of tests every time she came in, and that's not what we want either. So if we can have a conversation and talk about what we're worried about and what's urgent for now and what can maybe wait to see how things go, then that puts us all in a much better position. So as parents, we talk about junior doctors as being startled rabbits, because when they walk into a cubicle and they see our kids in their wheelchairs looking really complicated, the face that they have pulled is a real picture. And you almost feel that you want to help, you want them to feel confident, because actually they are your route to getting my daughter looked after well. And I don't want them to be panicking. I don't want that reaction. I want them to walk in and be able to say, this is going to be complicated, isn't it? But we're going to get through this and we're going to understand it together, and I'm going to help. And just have that approach of, do you know what? You know stuff. I know stuff. We need to put that together and figure out what's going on.
I love the idea of all these startled rabbits. And I want to say something to the rabbits. I want to tell them that this isn't their problem alone, and that all of us work together, and they should never be scared to ring for help. Because I think, Karen, you said you just need to ask for help. You need to get another opinion. You need to talk to somebody who knows that child well.
Absolutely. And I do it all the time. If I don't know what's going on and can't work things out, it's phone a friend. I think the other thing that can sometimes be very helpful is when you meet a disabled young person for the first time and they're ill, you're not seeing them as they usually are. So you don't really have a picture in your mind of what life is like for them. So just ask the parent carer. They might even have a photo or a video to show you what a good day looks like, so that you've got a better idea in your head about how and why things are different.
I think the other thing, as a consultant, I actually never mind getting a phone call. The thing that scares me is when I don't get the calls and I come in and I find a really complex case and everybody's frightened and worried and anxious. That's the parents and the junior doctors and the patient, and I didn't know anything about it.
I completely agree with what you've said, and I get very cross if I find out that one of my most complex patients has been through the hospital and things haven't gone quite right and nobody's rung me. So I make it clear on the emergency healthcare plans that I give permission for people to contact me, including out of hours, because it's so much easier to troubleshoot with somebody who knows the child or young person well rather than with a completely new team.
And I think in the middle of the night, you might not want to wake a consultant up, but you can always send an email. So you can just drop a quick email, and then if I choose to respond, because I read my emails all the time, including in bed, and I know the phone should be downstairs.
If you're interested in a career in paediatrics, the best specialty in medicine, please see www.rcpch.ac.uk/careers. This podcast was brought to you by MediSense Medical Education. Learn medicine differently through podcasts, games, videos, role plays and more at www.medisense.org.uk.
So the other thing that I would always ask from those doctors, members of staff in the emergency department is to believe what it says on the emergency healthcare plan about active treatment. So I knew that Eleanor wouldn't have a long life, but while her life was valuable and she was having occasional periods of ill health which required a stay in hospital, her life was worth saving and her conditions were worth treating. I've always found that doctors in the emergency department are quite quick to think that this episode will be the last episode. And actually that's really tiring, especially when you've done it 3 or 4 times over 2 or 3 years. Because Eleanor is very acutely unwell when she comes in, but I know that she bounces back from that very quickly. And actually, when she did come to the end of her life, it was very different from any of those stays where she'd been acutely unwell in hospital. Those acute illnesses were not going to be the thing that caused her death. And yet every time we went in, we still had to have the conversation with a doctor who didn't know her about, do we want to have antibiotics? Well, the healthcare plan says we're going to treat with antibiotics, and the healthcare plan says we're going to treat with oxygen, and the healthcare plan says we're going to treat diabetes. And nothing has changed since we wrote that plan, between writing that plan and coming into hospital, that says we don't do that. So actually, in that emergency department, we treat, unless there's something very clear to say, don't treat. And the pain that puts families through is really unnecessary.
Even for children with the most complex of healthcare conditions, 99.9% of the time, they should be afforded the same high-quality healthcare as any other child in any other situation, because they will get better and get back to their usual situation for themselves and their usual enjoyment of life. And I think it's really important that all doctors, nurses and health workers understand the equal rights of disabled people to the best outcomes.
I think junior doctors do know that children with complex health conditions can get better, but they're scared of these difficult conversations because it's a really hard conversation to have. And I want to know from both of you, how do they start that conversation? Because I don't think that junior doctors need to make that decision, but they need to start that conversation. Caroline?
I think one of the most helpful questions that I've been asked is what am I worried about? Giving me the opportunity to say what I'm worried about opens up a whole world of things, because there will be a point where I say I'm worried she's going to die. I'm worried that we're missing something. I'm worried that there's something going on that I don't know about. I'm worried that she's more ill now than she has ever been before. And I'm much more likely to say that if I'm asked the question about what it is that's worrying me most at the moment. And maybe that's a question that you need to ask more than once and at different stages. But there is, as a mum, there is almost always a question on my mind or a worry on my mind. And I have really vivid memories of being stood next to hospital beds, in cubicles or behind curtains with a doctor there, wanting to ask a question or wanting to say something, and struggling to do that because I don't want to look stupid. And I'm a really fortunate person. I'm articulate. I've worked in the NHS for a long time. Those environments don't really throw me, but it's still a really powerless position to be in. So somebody saying to me, tell me what you're worried about, just gives me a little bit more of an opportunity to be able to express that.
Tell me how you think that parents who are experts in the care of their children with complex health conditions struggle to get the right treatment for their children when they bring them to hospital.
So I think the major issue there is doctors and nurses not listening well enough, and not listening and really hearing, and not giving parent carers an opportunity to say what's worrying them and what they think is going on. And that can be a barrier. I think also we medics need to be honest about what we can and can't do. You know, sometimes health conditions are so complicated that you can't predict all the different things that might happen, and you need to keep a really open mind about what might be going on. And I think sometimes, from working with a lot of families, having the lead professional open up those most difficult conversations of all about, well, what might happen if I come in the morning and my child's not breathing? What do I do? Who do I call? And you don't need to talk about those things all the time, but I sometimes find that having opened it up, had that conversation, talked through, well, these are the practical things that we could do. This is the right person to call. This is what we don't need to happen, and putting plans in place can actually then be reassuring for families when they are faced with that sort of a scenario.
And there's not a family in the country that won't have had those thoughts. So asking the question won't put a thought in somebody's mind because it's already there. So I spent 21 years of Eleanor's life being scared to open her bedroom door if she was quiet in the morning, because quite often I would come downstairs and she'd be babbling or she'd be giggling and you could hear some movement or some activity. On those days when she just overslept, I opened the door really cautiously because I didn't know what I would find. But I genuinely don't think I ever had a conversation with a health professional about that until she was an adult. So that's a lot of years of worry. It's a lot of years of me thinking I should have a conversation and not being brave enough to have it. When actually, if somebody had said, we should talk about this, we should talk about what happens if something unexpected happens, that actually would have been a really difficult conversation, but it would have been a difficult conversation that was worth having.
There's two really important points here. First of all, that children can get better from things as serious as sepsis, and like you said, Karen, 99% of the time they do. And the second point is that every parent has thought about the death of their child but doesn't want to talk about it, and we're not helping them to do that.
And I think it's not necessarily that families don't want to talk about it, but I definitely think there are very few spaces opened up to them to talk about it. It's a really difficult conversation to have at the end of a routine child development centre or paediatrician appointment. It's something that requires some thought and some space and some time. And interestingly, when Eleanor moved to adult services, it was one of the first conversations that we had, because she was coming into adult services because she was unwell, and the consultant came and sat down with me and said, I'm not saying that Eleanor's going to die now, but we need to think about how you would like that to be, and we need to think about how you can have that conversation with me and with the rest of the family and with her brother and sister about what's important and where we draw the line and what that could look like going forward. And that was really upsetting, but it was the right thing to do. It wasn't upsetting in a bad way. It was just sad to have to think about some of those things. And I'm really grateful for that doctor who sat down and had that conversation with us, because it put us on the right path for the future over the couple of years that came after that.
And if you were a less experienced doctor, if you were a junior doctor and you were there in the case that Eleanor had got sick, how do you want to just approach that subject? How do you want them to approach that subject?
That's a really difficult question, because I think a lot of the time for our children who are very complex, their care is led by a consultant, whether that's on a ward or at home. But at the same time, there are opportunities, particularly when you're in a hospital cubicle for a while and it's the junior doctor that you're seeing a little bit more, where you can get to know each other a little bit more. And it's about having that trust. It's about being able to form a relationship, being able to understand what a family might want and allowing them to open up. So although I wouldn't expect to be having that conversation with a junior doctor, I might expect a junior doctor to say, are you worried about this? Is that something that's on your mind? Can we get somebody else to talk to you about that? And just start to ask some of those gentle questions that allow thoughts to form and allow words to follow them.
So that's just so important, that as a junior doctor, you should assume that these children will get better. But you could make the space just to ask the parent if they're worried and if that's something that they're worried about.
I think that's absolutely right. There's a real intimacy about being sat next to a hospital bed with a sick child, especially a complex sick child. I'm always quite comfortable in that little cubicle, and it feels a bit like an extension of our home. And actually, when I'm inviting medical staff in, I'm inviting them in. It's not their space anymore. It's a space that we inhabit for that short period. And I know that not everybody feels like that. But I think when you've been in hospital a lot of times, you have to be like that to survive. So it is quite an intimate space. It is the kind of place where you can have sensible, clear and compassionate conversations. And I think it's really easy to spot the people that are confident enough to have a compassionate conversation. And that doesn't matter whether they're a nurse or a consultant or a junior doctor, or actually the domestic on the ward or the person who brings in the cup of tea. You know, it's not about who that person is in terms of the name on their badge. It's about who that person is in terms of the way they relate to me and my daughter and that situation. I think it's about kindness, isn't it? It's really easy to spot somebody who's being kind. And I think what stays with you is the people that were kind to you. And that is totally, it can't be underestimated how important that is.
It's been really nice because actually Eleanor had a really positive experience. She got sepsis, it was recognised, she went home to listen to music and have fun and celebrate her 21st birthday. But it doesn't work out for everybody like that, does it?
It doesn't, no. And some families have a very different experience and some young people have a very different experience. And I think one of the... one young man who had a very poor experience around sepsis was a young man called Adam, and he was like Eleanor in some ways, very complicated disabilities, but actually he was also very articulate, and he was a poet who wrote a lot about his NHS care, but was also recognised as a patient leader, somebody who'd really tried to improve care in the NHS. I've got a poem here that he wrote while he was alive, and sadly he did pass away from sepsis, despite his family trying to get heard and really not being listened to. And his poem is here. He said, "I think everyone should have good care. So to help, I thought I would let you know what, from my experience, I think makes good care. In the good hospitals, staff talk to me and involve me in decisions about my care. They ask me about what I want and what I don't want. Staff talk to mum and dad and ask them about me. Staff talk to each other and pass on important information about me. If staff don't know something, they're not afraid to say and ask someone who does know. Sometimes that might be me or mum and dad. Staff treat me as an individual and recognise the things I can do. They don't jump to negative stereotypes and prejudices about me because I'm physically impaired. Staff have time for me. They're friendly and chatty and make me feel as if I matter. Staff are friendly and chatty to mum and dad. They work with them and they treat us all as if we matter. I'm never left alone when I'm seriously ill and never in a room with the door closed so staff can't see me. When I'm really ill, doctors come quick and do everything necessary to make me better. I'm not left critically ill for hours without care. I always feel that I'm getting the best care possible. I'm never made to feel like a second-class citizen for whom it doesn't matter if I live or die.
The Paediatric Sepsis podcast series was brought to you by the Royal College of Paediatrics and Child Health and Medisense, with support from Health Education England.